Now, the second talk is a bit of the ideal follow-up to the first one. Again, I will start from clinical science, but this time we will use the science in combination with MRI. I'm very fond of neonatal MRI, and I do think that MRI is excellent in giving us details on what we should expect in an individual child or in groups of children with specific lesions. But what has been amazing in the last 20 years since we started performing neonatal brain MRI, which was a sort of a strange concept 20 years ago, is that we have learned a lot from MRI and from the combination of MRI and clinical science in understanding what is the clinical meaning of some lesions, what is the association of lesions and clinical science, and as the ultimate goal is really to provide some prognostic indication for the family. So the way we use a combination of clinical and MRI findings goes both ways. It has been nice to see how we can explain some clinical science because of the lesions, but also once we have learned the association between specific lesions and specific clinical signs, we have also learned that we are not all very lucky to work in hospitals where you can have 5 MRIs in a month or so on. Very often people are in hospitals where it's even difficult to get one proper MRI. So we have used this information to see whether you can try to identify the children who are more likely to have bad lesions or more severe lesions on MRI, and so to give a priority or when and where to scan, and when to scan a child and what you should expect. What has been amazing when we started imaging babies 20 years ago was that what we knew about lesions and outcome was what we knew from adults. And very often in adults you have a lesion and then you have an abnormal outcome. And then we learned that with babies things are different, that not always even relatively large lesions had an abnormal outcome. And so we start feeling there may be some plasticity of the brain maybe that makes these babies behave different from adults or older children with the same lesion. And this is something that we will see at the end, and we will see this over and over again also when we talk about vision, is that sometimes in newborns you can have even large lesions that may or may not involve subcortical structures. And if there is a concomitant involvement of the subcortical structures, this is more likely to be associated with an abnormal outcome. Now, the MRI has been very useful because we had in the past seen many tools for defining outcome. In the 80s or in the late 80s, there have been a number of studies on EEG, on evoked potentials, or on clinical examination that if we are thinking of children with asphyxia, for example, there were excellent studies by Linda de Vries, by others, showing that even at 5-10 hours after birth, you can predict the children with normal and from those with an abnormal outcome. However, in many of the studies, there was a very clear definition of normal or abnormal outcome. But when we talk of abnormal outcome, if you are a neonatologist or a neonatal neurologist, and you have to talk to parents, abnormal is not enough. I mean, actually, these days, we don't even say abnormal any longer. Anyway, saying that there are going to be problems is not enough. You want to know more. Is this just motor? Is motor and cognitive? Is going to be a mild hemiplegia or a severe quadriplegia? Is it going to walk or is not going to be sitting? So we have tried to put together all this information, what we learn from MRI, from neurophysiology, from the clinical examination, trying to define whether there are MRI and clinical signs that together can help us in predicting prognosis in children. And I will start with children with asphyxia. Now, a few years ago, we published it. There are also many other papers on the topic, but I will bring our experience that when you have birth asphyxia in term infants, if we want really to oversimplify this, you can have an initial asphyxia where you have initial edema, and then if you repeat the scan at the end of the first week, you may find a normal scan, so just initial edema, and or you can see that the patterns can be largely very, this is a very easy classification in predominant white matter changes or predominant basal ganglia lesions, and things are never so simple or so well defined. There is very often an overlapping between the two. But this was very helpful in having some sort of general guidelines in prognosis and in associating this with clinical signs. When we talked about white matter lesions, we used to define these lesions as minimal lesions, very often where posterior periventricular lesions are sometimes a bit more extensive, or more diffuse lesions, but not completely diffuse, as in this case. So we had the 3 degrees of severity of white matter lesions. In these ones that I will label as white matter change, predominant white matter changes, there was cortical highlighting, but there was never involvement of the basal ganglia. And when we look at we follow these children for years. We started since the neonatal period, and we saw them regularly until 2 years, and then every year until school age. And when we assessed them at school age, we were able to perform a more structured examination. We were looking at an assessment of cerebral palsy. We were looking at minor neurological signs using tests like the movement ABC or the Tag1 examination. You can have some indications of whether there is no cerebral palsy, but still there be some clumsiness or some minor neurological signs. And we also looked at cognitive development. Surprisingly, we find that the great majority of the children who had mild to moderate white matter changes, even those with these moderate white matter changes, were often normal. Normal meaning no CP, no abnormal minor neurological signs, and no major cognitive signs. And only in a small proportion of them we found some minor neurological signs on the Tag1 or on the movement ABC. So we were pretty surprised, because you would not expect, from what we know from adults, that lesions as big as this can produce no abnormal outcome, not at 2 years, but even at school age. So this was quite surprising. And when we look at the children with the more severe white matter changes, the outcome was never normal. However, this is what I mean when you have to define your outcome, because you need some counseling for the parents. These children had an abnormal outcome. They all developed a cerebral palsy. They all developed a spastic tetraplegia. However, if you look at this child, it's a child who is sitting, who is interacting with the examiner, who is able to do something. There is a delay, but he's able to is able to go to school and to play with other children, and eventually at the age of 3 was able to move herself quite a bit and to walk with a rollator at the age of 5. So it's not a normal outcome, it's an abnormal outcome, it's a cerebral palsy, but it's not the most severe cerebral palsy we have seen. And we will see the evolution of signs in these children. They start very badly, but at the end they do have an abnormal outcome, but I would call it a relatively bad outcome. Things are different when we move from the predominant white matter lesions to the basal ganglia lesions. And again, the basal ganglia lesions can be minimal, and very often in asphyxia you have localized lesions in the lentiform, or they can be more diffuse but not completely diffuse, like in this case where this MRI at 18 months looks cystic, changes all over the white matter and the basal ganglia and the thalami. And we were surprised to see that with the basal ganglia lesions, we had only one child who had a completely normal outcome, and all the others had a severe cerebral palsy. Now, let's see what sort of cerebral palsy these children develop. And if the basal ganglia lesions are mild or mild to moderate, only one, I think, in these children had a normal, completely normal outcome. All the others had some signs, and very often they were dystonic signs, not always associated with cognitive impairment. We will see vision this afternoon separately. So basal ganglia lesions, even if they are relatively small, they are very likely to be associated with an abnormal outcome. However, if the lesions are mild to moderate, it's not the worst outcome. Things are completely different when we talk of these severe basal ganglia lesions involving all the basal ganglia and the thalami, where we have this dystonic tetraplegia that is very, very frequent. And these are the children who never acquire the ability to sit, who have poor swallowing, who have poor vision, And this is probably the worst prognosis we can give within the cerebral palsy spectrum. So it sounds strange. I mean, 20 years ago when we started, it was very strange that these subcortical structures are so important for defining outcome. You can have extensive parenchymal lesions with much less abnormal outcome than these. And there is usually, I try to give an explanation, but I wouldn't in front of Donna, so I will tell you at lunchtime. So if we want to have a summary of these, we can say that if you are dealing with predominant white matter changes, you can have minor or moderate white matter changes, and the outcome is generally normal, even at school age, even looking for minor neurological signs. If the white matter lesions are more severe, and some of them will fall within the border zone spectrum that Donna and Stephen has described very nicely a few years ago, the outcome is going to be abnormal, but it's generally spastic quadriplegia with some mental retardation, but it's not extremely severe. And walking can be possible, but is often delayed and usually with some help like a walker or something like that. If the involvement in the basal ganglia, the lesions can be mild or mild to moderate, and you often end up with an athetoid CP with variable cognitive development, and this is the worst outcome ever we see in asphyxia lesions. Severe basal ganglia lesions is a spastic or very often dystonic tetraplegia with severe mental retardation, severe visual abnormalities, and severe swallowing problems. Now, when I started, I told you I'm mainly a clinician and I'm interested in clinical science. So we started thinking not all places have good MRIs. Very often these children arrive to a later stage without a proper MRI, sometimes without an MRI. And so can clinical science help us to identify these children, or what is the evolution of clinical science according to the lesions? And the difference between the severe white matter changes and the basal ganglia is really striking. And here there is something I want to draw your attention, because this is probably the most common mistake we make in counseling patients with lesions. So these children start as newborns, very often with a severe hypotonia, but they have the anti-gravity movements, so we do know they are not neuromuscular. And they have swallowing problems, sometimes respiratory problems. There is a lot of hypotonia truncal hypotonia, and visual attentions can be very poor. So if you see these children in the first days, in the neonatal period, you would not be very happy because there are sucking, swallowing problems, hypotonia, and visual alertness is reduced. If you look at them again after a couple of months, I think this was 6 weeks, the quality of movements is slightly improved. There is an attempt to bring the head up. This was a video that, however, I wasn't able to start them this morning, and the visual alertness improves. So if you see them at 6 weeks, the tone is improving. Swallowing problems are usually much better, if not completely resolved. And the visual alertness has also improved. And if you see them between 3 and 6 months, this is the time when these children will fool you, because visual function has become completely normal. Swallowing problems are not there any longer, and if you go and measure their tone can be completely normal. So very often in the past, when we didn't know these things, we have been more optimistic that we should have been, because between 3 and 6 months is the time when the hypotonia is going to become hypertonia. So this doesn't happen overnight, switching something. It's a sort of a process where between hypotonia and hypertonia, you may have a few months where the tone appears to be normal, but just because it's going from hypo to hyper. So if you think vision has improved, swallowing has improved, tone has improved, we can be a bit optimistic. But then if you see the child again at 1 year, between 9 months already and 1 year, you will find an hypertonia. And this was actually the same child I showed you initially. So be careful when you see children with moderate to severe white matter changes, that if you only see them at 3 to 6 months, or if you see them again as part of your follow-up to 3 to 6 months, the examination may fool you, because everything looks completely normal, but only because it's a transient phase between hypo and hypertonia. So these children will not have the worst outcome, but they will still develop a cerebral palsy. We cannot be too optimistic with parents. Things are different when we talk of basal ganglia, but if we want to look at the scheme of evolution of clinical signs associated with white matter, you can see that in the first month you have hypotonia, abnormal movements, abnormal vision, and abnormal sucking. At 3 months, between 3 and 6 months, this becomes normal, and the tone is probably in intermediate here, so you can be fooled. And from 6 months, especially around 9 months, in the most severe, in the most severe cases already 6 months, in the milder cases at 9 months, you will find the hypertonia that is still there. But what is good is these children usually never get vision or sucking problems. Things are different with the neonatal signs, because the basal ganglia lesion are the only children where you don't see a lot of hypotonia, because there is already, very often there is already an increased extensor tone. So these are the children we have seen previously in the differential diagnosis. Do I have the pictures here? No, but you have seen this morning. Sorry about this. You remember the flexion in the upper limbs and the extension of the lower limbs. You remember the increased extensor tone. When you have all these signs are already present in the neonatal period, and very often they have some cyclic movements. If you see these children in their crib, they will start with some cycling movements. And I do remember now 20 years ago, at the time when we were learning these things from MRI, that coming from an epilepsy background, I was convinced that they were cortical seizures, and I was sticking electrodes all over these children trying to find an EEG seizures. But these cycling movements are often not associated. They're probably subcortical seizures. They're not associated to any EEG abnormalities. And so is increased extensor tone, is upper limb flex and lower limb extended, is cyclic movements, is abnormal toe posture, the curling of the toes I showed you 15 minutes earlier. They have poor early visual and auditory attention, and sucking difficulties. Now, what is very bad in these children, these signs are persistent. So if you see them again at 3 months, 6 months, 9 months, 12 months, unlike the white matter changes where you had seen how many of these aspects of these features normalize over here, these are all permanently abnormal. And this is a case of someone who had already had an extensor tone in the neonatal period. There was no visual attention. There were sucking problems, and this child died at 18 months with an aspiration pneumonia, and she was never able to sit independently because of the extensor tone. So the presence of these deviant signs is very important. So do remember when you perform an examination, I know that many of you, if you're here, you have excellent MRIs and you will probably get this information, but your clinical examination can give you an extra indication on the prognosis if you see these abnormal signs. So be very careful to these signs. If we go to preterm infants, things are not too different if we think of infants with PVL. And in a study performed a few years ago now, we looked at the posture of the legs and the posture of flex arm and extended legs. And we saw that all the children who had abnormalities with the flex arms and extended legs were unable to sit by the age of 2 years. So it's very important that you recognize these signs, because children who did not have these abnormal postures all had a normal outcome, and they were able to walk by 2 years. Children who had some dystonic posturing with some extended legs, but not the full pattern, were able to sit but not to walk by 2 years. These are the children who may be able to walk later. And children who had this full flexor tone and extended legs never achieved the ability to sit independently. So this is an important piece of information you want to give to the parents. And these are the pictures when you see this extensor tone and this discordance between flexor and extensor tone and this posture. Unfortunately, this is very likely that if these signs are persistent, again, you don't want to see them for 3 minutes when they are crying. If these signs are persistent, it's unlikely that the children will ever sit. And the same applies to the prevalent extensor tone. The children who had that postures and the prevalent extensor tone were never able to sit. So altogether, we can say there are clinical correlates of brain damage that can help the clinician to define the abnormal outcome and to have a better idea of the severity of the sequelae. And I think we do need to give parents more information. I don't think it's going to be, I mean, I see parents as a neonatal neurologist, but I'm sure that the same question they ask me, you will be asked exactly the same question. You know, is he going to walk? Is this going to be only motor, or is going to be cognitive? So if you combine MRI and clinical information, you can provide, I mean, you have always to be cautious because there are, as we will see in a moment, there are a number of other things we have to consider, but these are, if you put together clinical and MRI information, if the MRI show you severe PVL or severe basal ganglia and you have the extensor tone, I'm afraid there is always some room to be a bit optimistic on something, because we cannot be so negative with parents, but our room for optimism is much more limited. Now, I want to go back and quickly go through some slides in trying to define why children with babies, newborns with lesions sometimes have a better outcome than we would expect if we compare them with older children or with adults with similar lesions. And this concept of brain plasticity is a concept that's relatively new for clinicians. Until we performed serial MRIs in infants, we didn't have any idea, because very often we only saw the children if they came to see us as neurologists because they had a motor problem of epilepsy. And since we started doing more MRIs, we have identified a number of infants who have lesions who then have a normal outcome. So the problem is to try to understand again if from MRI and from clinical information we can identify children who have more chances of having brain plasticity. And this comes from the observation that we do see variable outcome in patients with similar cortical lesions, and we have tried to identify early markers. Now, one thing that we can already say from what we have just seen is that if there is an involvement of subcortical structures, the chances of brain plasticity are less likely. Now, I was not going to tell it, but I will tell. So, Donna, can you put your hands on your ears? And the way I have been explained this some times ago was that you have to think of, let's say, Italy. You know, Rome is in the center. So if you want to go from Milan to Sicily, you have to go, you can fly, of course. But if you want to take a train, you have to come through Rome. And the way I have been explained this is that the basal ganglia are the sort of central station that connects the important stations from the north, from the south, from all over the other places. And if the central station is stopped, and the basal ganglia or the other subcortical structures, the thalami, are stopped, then there is very little chance that information from the north may arrive to the south and the other way around. So what I have been explained is that the subcortical structures, they are so tiny and they don't seem, I mean, we have always been told when we were studying neurology that the cortex is what is important in the brain. Apparently it doesn't apply to the children, because these subcortical structures are really the key for understanding plasticity in these children. Because if the subcortical structures will stop, we have seen a beautiful picture from a diffusion tractor imaging on how the thalamic connections were interrupted. If these connections are interrupted, the chances of plasticity become less. So be careful, don't think just about the cortex, think of the subcortical structures and understand the meaning when you see them on MRI. And if we want to understand more plasticity, it's probably easier to go to a better model that is a focal lesions. Donna will tell us all about infarcts today, so I'm not going through the infarcts, but I think it's important to go through the slide quickly through the infarcts to understand a bit of plasticity. And in the past, we have published a paper where we saw that sometimes we had extensive lesions involving the whole hemisphere that had a normal outcome if the basal ganglia or the internal capsule were not involved. And what we have learned is that if you have a combination of all three, so it's not only the cortex or the white matter in the hemisphere, but the subcortical structures are also involved, these are the children who will develop the hemiplegia. There is less plasticity. But we can have a similar lesions in the hemisphere with normal basal ganglion, with normal internal capsula, and they will end up with no hemiplegia and normal cognitive development. So involvement of subcortical structures is very, very important. And this is a paper we published a few years ago where we saw that the only children who developed a hemiplegia in a relatively large number of children with stroke were the one where there was a concomitant involvement of all the structures. Now, why is this important? And this brings us to, this is vision. We will see it this afternoon, so I will go through this. But the involvement of the other structures does not always explain, again, the variability. So there are other factors that we should consider, and timing is another factor. What we have seen is that sometimes you can have exactly the same lesions, but children may have a different outcome. And again, we look at the stroke because it's a good model, and we compare the neonatal stroke with other strokes occurring in children, but at a later age. And when you compare the stroke, sorry, I have to rewind because I didn't remember there was this slide. This is a stroke with a child who was born with a cystic lesion. So the stroke occurred antenatally because the lesion was already cystic. And I hope this is a shame because these are twins, and you can see that this child is moving very nicely, and this child only moves this leg, but not this leg. And this was already obvious in the first few months of age. So if you have an early lesions, if you have a prenatal lesions, that will give exactly the same lesion that you see in the perinatal lesions, you can see that the signs are earlier and they are more severe than in the perinatal lesions. So the timing of the lesions is another factor that we have to keep in mind. And this applies not only to the prenatal and perinatal lesions, but also applies to the lesions that will occur later than in the antenatal period. And James Boardman, a few years ago, compared neonatal infarct strokes with childhood strokes, and you can see that the incidence, the number of children who developed a hemiplegia in the neonatal strokes was much lower than in the one with the childhood stroke. And you can see that the chances of developing a hemiplegia, even having just the cortical and basal ganglia without internal capsula, was also high in the childhood stroke, but never occurred in the neonatal stroke. So the timing when the lesion occur is important. And apparently the perinatal period appears to be the sort of golden time of when you don't want to hemiplegia, because if the lesions are too early, prenatal, there are higher chances of developing an early hemiplegia, or if the children occur too late, after the neonatal period, the chances are again higher, even when the lesions were similar. These were matched to involvement of basal ganglia, cortex, and plic, posterior limb of the internal capsula, and you can see that how we never found hemiplegia in all these groups, but there were some in the childhood stroke. And this is something I will move to vision, and just to show you that sometimes from what we learn from neurology is that if you have a lesion in the occipital lobe, especially if it's involving the medial part of the occipital lobe, you are due to have a visual field loss. And if we look at these 4 cases, we see that this child had a contralateral visual field reduction, but this child didn't. And this child had bilateral loss, even if the medial aspect were relatively spare, and this child didn't. So this looks very strange, doesn't it? And the timing was different, and all the one with perinatal lesions who did not have involvement of the basal ganglia, this one were perinatal, and this one this one occur after birth. So the timing again explained a difference in outcome. So I don't want to go through all this, but just as a conclusion, I think we can learn a lot from associating brain MRIs and clinical findings. And I think this is very important because we can all learn from MRI, but in clinical practice we have to give indications to the family. So a good an integrated approach of all this can give you indication. And I think if we want to conclude, is that we have to look to subcortical structures and we have to look at timing, because these are the two key issues. Of course, there are other aspects that I had here, but I can see from your face that it's getting too much. There are other aspects that are important, but as a neonatologist, as not an expert in this field, if you understand the meaning of subcortical structures and the timing of the lesions, and you do a proper clinical examination, there is enough to give a better prognostic information to the families. Thank you. Anyone awake? Yes, too. Yeah.
I have two questions. The first one is if you have some experience about the outcome in the case where you have mild white matter lesion, and you told us that you have a normal outcome. But what about neuropsychological problems and so on?
I was talking of full-term infants with a relatively mild asphyxia. Of course, if you are a preterm infant with mild white matter changes, things may be different because of timing, because of different lesions. So what I showed was within the spectrum of asphyxia, and that's what we found at school age. I think now we have probably double the number of the series that was shown a few years ago, and you can have some cognitive impairment, but usually not with mild white matter changes. You need at least moderate white matter changes. Francis Cagwan made a more recent paper on cognitive and white matter changes, but they were more diffuse and they were always minimal hints that there may be something in the basal ganglia. I mean, not predominant basal ganglia, but they were not completely normal.
I see. And another question is, when you talk about the Windows period when you switch from hypotonia to hypertonia, do you see if they have some abnormal general movements?
Yeah, you do, yes. That's what is exactly the point, what I said, that you really need to do you have a wider mind and not to be just with the neurological examination. This is the time when I think the examination is very often. Now, the problem with the general movements is that very often you can, the best time that I find, I mean, I'm sort of semi-expert in general movements. I'm not the expert, but I have done enough training and I've worked enough with other people to know. So I think the 12, 16 weeks fidgety is still the best time for prognosis. Between 12 and 16 weeks is usually when you start seeing the fidgety, children start doing all these sort of nice movements. And this is really the absence of fidgety, as they showed I think there was a paper on Lancet 10 years ago now by Prechter, Giovanni Cioni and others. This is really the time when you have the best prognostic indication. However, with the quality of movements, you will not arrive to a defined diagnosis whether this is going to be a dystonic posture, dystonic. They have tried to do this correlation, but I do find it very, very, very useful in the infarcts and in the white matter changes around 16 weeks. I think is the best time where the general movements will probably tell you more than the neurological examination.
Okay, thank you.
There was another question over there. Is that?
I've heard a discussion between David Edwards and his own follow-up people about the utility of doing an MRI in tiny preterm infants as a discharge prognostic indicator. And I know that a lot of the follow-up people are very enthusiastic for that, and other folks think it's basically a waste of money. And I was curious about your thoughts about MRIs for tiny preterm infants who otherwise don't have, major bleeds or something like that.
I used to be one of the follow-up people, so I'm afraid you already know my answer. I think we don't know enough about it. We have been trying to understand a bit more. I think there is a correlation. Again, it really depends on what you're looking for. If you're looking for DAISY or you're looking for minor changes, they may not always be associated with an abnormal outcome. But I do think it's important to look at the how the brain has matured at term age and what sort of lesions you have. And I don't think we know enough to have a specific question. I don't think it's a waste of time, actually. And especially with vision, we are working on vision. We have found an amazing correlation between some aspects of MRIs at term age and visual outcome at school age. So I don't think it's going.
But is that as a research tool or as a general clinical practice?
All tools, until you understand perfectly well what they mean, are research tools. And I mean, what I showed today when I was doing MRIs in 1993 in London, when I arrived, they were research tools. But now, if we use them as clinical tools, and we can understand from when I talked about reverse medicine, is that why you do research medicine first, because you want to understand what is the power of your tool and what is the correlation with your clinical examination. Once you understand it, you may skip some MRIs, because from your correlates with clinical examination, you may decide it's not worth it. But first you have to do it, and you have to understand what is the correlation with the clinics and with the outcome, and then you can make your decision whether you have to make it or not. In my mind, we still don't know enough to make sure whether, but I would still, if I had the opportunity in the hospital where I work now to have a consistently a term MRI, I would happily have it.
So I'd be curious, how many people here have relatively routine MRIs done on very preterm infants at term? Oh, a fair number. Okay, so that's interesting. I mean, I don't think there's a consensus on that about how to proceed with that.
I think the consensus is that we know a lot, but we don't know enough. and therefore we need more. Roberta?
Eugenia, I've been very impressed about the differentiation, the accuracy of differentiating two children, one with a moderate basal ganglia injury and the other one with severe basal ganglia injury, how different they can be on the follow-up. Can you tell this from the very early MRI, let's say at the first week of life, or you say that during the follow-up, like MRI at 6 months?
Well, you wouldn't say it before the end of the first week, but even at the end of the first week, there are still acute changes. So probably a second MRI, when the changes become cystic, will tell you more information. But very often, if there are diffuse severe basal ganglia changes, you can already say it by the end of the first week. It would be more difficult in between the not completely severe or the severe moderate. You know, the sort of intermediate, you may not be completely able to do it. But in the very severe cases or in the relatively milder cases, very often you can already say it by the end of the first week. I don't know what Donna thinks about it. I can feel that the next question is where is lunch to be served? No, there is another question.
In practice, we find that there are parents who say there are abnormal signs, but why should I do an MRI? It's not going to help me from the treatment point of view. I will treat the child just as we see the signs. So why should we do an MRI? And that's always a problem, because we at our place have to do an MRI under general anesthesia. And that is one of the drawbacks.
Yeah, well, there are several reasons for doing an MRI. The reason why today I try to do a combined, sometimes I give this talk with more emphasis on specific findings on MRI, and sometimes I put more weight on the clinical findings. Today I decide to put more weight on the clinical findings, because I know there are many places where having an MRI is difficult. Why do you need an MRI? Because MRI will give you details. I mean, we have seen that if you know that there are basal ganglia lesions, the outcome is more likely to be abnormal. If you want to start a rehabilitation program, well, first you can identify the children who are more likely to be normal, and then you can tell the parents, you know, you have to be cautious, but you say, generally, statistically speaking, these mild lesions are associated with a normal outcome. So this is a good reason to have an MRI. But also, if you think that the findings are going to be abnormal, then you can also think of what are the likely abnormalities that are going to happen in terms of vision and so on. And so you can start a different, probably observation or rehabilitation process in these children. If you know that these children are likely to have a visual impairment or a dystonic posturing, you start also your rehabilitation approach. I mean, here I'm putting a different hat of the person who works in rehabilitation and with children, but knowing what is the likely outcome, it will help you in deciding what sort of treatment these children are going to have.
I would say the other reason to get that MRI is to really make the diagnosis. You're assuming that
sure.
a baby who is
Sure,
encephalopathic in the newborn period has experienced hypoxic ischemic encephalopathy, but it may be something else.
Yeah.
5% of our babies with neonatal encephalopathy actually have strokes. Wouldn't you like to know where that stroke is? Wouldn't you like to know if there's a prothrombotic condition associated with that, so you could counsel the mother for the next pregnancy? Some of these babies also have brain malformations that are genetic diseases, and you need to find out what they are so you can counsel the family if they're going to have other children. So I would say not just for outcome and correlating outcome, but more importantly for diagnosis.
Yeah, no, absolutely. No, I gave for granted that we didn't. Yeah, and also because there are a few studies showing that that the encephalopathy can be just an epiphenomenon of something which was already there before birth, and then you have a asphyxia or encephalopathy on top of something which was already there. So
I think with the new high-quality sonography, you can get a very good imaging today, which is almost as good as an MRI.
mm-hmm.
And I think that concerning the
do,
colleagues'
do,
question
do you
about-
do you come from Utrecht?
No,
No.
South Germany.
Okay.
And then I think if you really want to perform an MRI, you can wait. You don't have to make it a discharge, and then you don't have to make it with general anesthesia. Today, with a propofol or with disoprivan at the age of 2 or 3 months, you don't have to bring the baby to the risk of general anesthesia.
Danilo, did you have some? I agree. Danilo, did you?
Well, it was some of the same question of
Okay.
your colleague,
Okay.
of timing. It was important. Thank you.
How can coexisting cerebellum lesions affect the chance of plasticity in these babies?
Sorry, can you say?
Coexisting cerebellum lesions, how can they affect the chance of plasticity, please?
Good question. We looked at the cerebellum in asphyxia, and we couldn't find really, I'm talking about asphyxia now, we really couldn't find any major involvement of the cerebellum, or unless there was a more general atrophy. Sometimes you have a subtentorial and supratentorial atrophy, and then it's difficult to be sure of what is what. Cerebellum is probably more important in PREMS. What we do see is that when PREMS have associated cerebellar hemorrhages or associated cerebellar lesions, then the outcome is definitely going to be unlikely. But in asphyxia, I don't remember specific association. We did look at it some time ago, and we were not impressed by this association. Donna, do you have your experience with?
Cerebellar hypoplasia is common in babies in the encephalopathy of prematurity, especially if there has been postnatal exposure to steroids. The other possibility in a term baby when we see cerebellar lesions is to start thinking about congenital metabolic disorders like disorders of glycosylation, muscular dystrophies, and things like that. So I think in that way it contributes only because it broadens the difference.
It's broader, but in the pure asphyxia, it wouldn't, There is a whole world with cerebellum. I mean, we are looking at it as part of an Italian network at the large numbers of cerebellar hypoplasia, and we were impressed that if you repeat the scan by the age of 2, many neonatal cases where you are questioning whether is an increased cisterna magna or is a vermis hypoplasia, actually they look much better at the age of 2. And also the cerebellum is really the marker for so many other things, that in the one where you see persisting signs of hypoplasia, especially if there is this associated dysplasia like cerebellar cyst, then you open a completely new world for diagnosis, for differential diagnosis. Okay, lunch is outside, and Thank you.